Thank you very much, my good friend. Why would we wait? Yeah, that's a good question. We would like to optimize the fluid status as soon as possible. And I don't think that the place where we are plays an important role. It could be the operating room, it could be the intensive care unit, even more commonly. It could be the emergency room. It's more a matter of stage in the disease process that will really count. We all know that we have to navigate between hypovolemia and what we could call hypervolemia, although Michael Pinsky and I just wrote an editorial where we propose to be cautious about the use of hypervolemia. What do you mean by that? It could be edema, but edema does not mean hypervolemia. You could have edema and be relatively hypovolemic. So you can read that editorial. The point is that when we insist on the fact that you give too much fluid, we may actually end up in a situation where after a meeting like this, people return to their hospital and say, no, I heard you're giving too much fluid. Just give vasopressors. Vasopressors without fluids. That's terrible. That's the route to multiple organ failure. The patient will not have major edema. Okay. But the patient will have renal failure, bowel ischemia, etc. So we need to monitor. That's the point. Because we need to evaluate the benefit-risk ratio when we give fluids. As Xavier explained very well, the benefit is the increase in flow, the increase in cardiac output, and the risks are an increase in cardiac filling pressures, an increase in venous pressures, resulting in more edema. And we don't like it. Of course, we shouldn't like it at all. So I'll give fluids only to correct hypovolemia, right? Wrong. Because, of course, we need to correct hypovolemia. But our patients are often vasodilated when they are septic, or after a major surgery, or in polytrauma, or in pancreatitis. These patients are typically vasodilated, so we need to fill the tank. And also, we would actually like, in some cases when there are signs of altered tissue perfusion, we would like to reach a cardiac output that's even a bit higher than when you just correct hypovolemia, because that would be a way to bring more oxygen to the tissues. So we know that everybody being healthy could be fluid responsive. And actually we could use that, this fluid responsiveness, to increase cardiac output above the baseline value. So what we want to do actually is to restore blood pressure and restore tissue perfusion even more. So we look at the skin, we look at the urine output, we look at the mental status, especially now that we use less and less sedation. We can evaluate the mental status of our patients. And as discussed in another session earlier, we could look at lactate levels repeatedly to make sure they do not go up, and if they are elevated, that they go down. And we would like to avoid any excessive tachycardia, of course. But the price to pay is the risk of edema. So we should decide to raise the question of fluid administration only when we identify that problem. Maybe a bit difficult to quantify the degree of peripheral perfusion, we could try, but at least we should try to quantify. And by themselves, signs of fluid responsiveness are not sufficient to give fluids. Again, I am probably fluid responsive right now, and I do not need fluids. Healthy individuals are fluid responsive. So we cannot go by formula. We cannot say this patient will need 1 liter of fluid. How can you say that? No, you cannot. Oh, we will do a trial with more fluid or less fluid. Ridiculous. We need to individualize our therapies, personalized medicine. And we know that a single variable alone, regardless of its value, will not tell us whether the patient will benefit from fluid. That's very clear. So, again, if we want to give fluid, it's to increase oxygen delivery. We don't want to have an excessive increase in cardiac filling. And that's how, if given variables will not tell us whether the patient will benefit from fluid or not, we need a dynamic evaluation. And that's why we need the proper monitoring system. How many patients will respond to fluid? That's highly variable. Xavier said maybe 50%, but it could be less than 50%. If you use these tests in very limited cases, you will find that not many patients will respond to fluids. Or if you use it very liberally, you may find that 70%. But it doesn't matter. The point is that all patients will not respond to fluids even when they are in shock. So we need to evaluate the system. When we give fluids, we basically increase preload, right? Cardiac preload, right ventricular, left ventricular preload. And we hope to increase cardiac output. But if the heart does not accommodate that, there will be an increase in filling pressures and more edema. So indeed, should we measure cardiac output when we do this test? Yes and no. Maybe we could do without it. But in complex cases, it's certainly better to measure what we do. And this is my old slide. Because the question is, could we start in the emergency room? Could we start anywhere in the hospital? And I would say maybe not in the very early stages, especially if the patient is obviously benefiting from fluid administration. So from this old slide, we went into this newer slide with the SOSD phases. I think it's important to refer to that. It's just a simple scheme, nothing else, and the periods for each phase can vary from one patient to the other. But the idea is that during the salvage phase, in the emergency room, early on the floor, anywhere, we just try to keep the patient alive. We just pour fluids, we pour vasopressor agents early, but we should try in these conditions to insert the monitoring system, to have the monitoring system available as soon as possible, so that we can move into a optimization phase. Very important. Now we optimize, because indeed we do not want to give too much fluid to our patients. And as Xavier indicated, we could perhaps simply look at signs of fluid responsiveness in patients who are mechanically ventilated, using this test of increased intrathoracic pressures that could result in pulse pressure variation or stroke volume variation if the patient is still on the ascending limb of the Frank-Starling relationship. We just heard about it, and we heard that this works only in mechanically ventilated patients, patients who do not stimulate the respirator. So usually it requires sedation. And of course, no major arrhythmias, small tidal volumes may be a problem. If you look at all these studies on pulse pressure variation, stroke volume variation, including ours, patients were profoundly sedated. So it works well in the OR. But you asked me, what about outside the OR? Patients are no longer sedated. And when they are when we evaluate them. And of course, there is also a gray zone, as we know, where we are not sure that the patient will respond or not. Trying to evaluate changes in vena cava size, that's not very reliable. This is a meta-analysis for the inferior vena cava. You can see that some studies report good results, some others not so good results. It's really spread out there. And if you look at superior vena cava, it's not much better. These patients were sedated, paralyzed to get these measurements. And you can see that the curve is actually not very good in terms of sensitivity and specificity. So external fluid challenge, yes, indeed, as indicated, we could do a little test evaluating the benefit and the risks. That's what we currently recommend with the Surviving Sepsis campaign. Or in children, the American College does the same, even in children, in neonates. They recommend to look at benefit versus risks. But that can be relatively invasive. And then you give small amounts of fluids over a limited period of time. And you evaluate the patient's response. And again, it would be better to have a cardiac output measurement. The point is that if the patient does not benefit, we should stop fluid administration. And I think that's a very important point. People too often think that a fluid challenge will encourage to give more fluids, but it's the other way around. It should encourage us to stop if there is no benefit. And finally, indeed, there is what I call the internal fluid challenge. I think it's very smart to use the passive leg raising test to mobilize the patient gently. It must be in a relatively quiet environment. We are in the optimization phase. And then indeed, there could be a transient increase in stroke volume with the procedure. And indeed, with bioreactants, if the time is limited, we could actually catch it. Now, it's not so easy. We need to learn how to do it, because if we stimulate the patient, of course, blood pressure will go up, cardiac output will go up. It's just the stress of the non-sedated patient. And Xavier and Jan- Lui presented very clearly in that open access paper, you can read it, how to do it. But they insist on the fact that we should not look just at blood pressure, we need to look at changes in cardiac output, or stroke volume even better, over a short period of time. But that's the future, I think. That's what we wrote in our ICU in 2050 with Luciano Gattinoni and Art Slutsky. We said, in 2050 we will no longer be present on Earth, but we could imagine our child being in the bed, and the bed will move around, and there will be sensors, and that's how fluid responsiveness will be evaluated in the future. So this is the future. But clearly, it's not just the science of fluid responsiveness that we will treat. Look at this paper, very good paper on healthy volunteers, showing that healthy individuals can increase their cardiac output quite markedly with fluid administration. So fluid responsiveness says what it says. If you want to increase cardiac output, if the patient is fluid responsive, you could then use fluids. So the correction of fluid responsiveness is not a goal. We need to individualize the problem and then indeed see whether or not we could use fluids to try to alleviate that problem. So that's something that we sometimes miss. When you talk to the young residents, sometimes, oh, the patient was not well, oh, the patient was terrible. What do you mean? Not well, terrible. We need to identify the variables that we are trying to correct, and then we need to choose the right monitoring systems. Yeah, we need to choose it, because we will have to measure, to interpret, and apply. regardless of the monitoring system, if we just measure something like cardiac output or stroke volume, and if we don't do anything about it, it will not help the patient. And if we do something about it, it's because there was an intermediate step of interpretation of this test. So now I like to refer to the three challenges in a dynamic way. Fluid challenge, external, internal with passive leg raising. Vasopressor challenge. Speak about it in other sessions, but we need to optimize the blood pressure level. And if the patient does not respond to fluid, if the patient is still highly dependent on vasopressors, think at the butamine test, a test. Again, a test, a challenge, and we will see how the patient responds. So, identifying the problem is important. Evaluate the risk-benefit ratio of fluid administration is, of course, extremely important. And we need to monitor the patient's response. And indeed, the bioreactance technique may be one way to evaluate the changes in stroke volume during an internal fluid challenge associated with passive leg raising. So I don't think we should say that we need to do that and only that. I think we have several options available, and it should not be limited to the OR or the ICU, wherever the patient is. If we are in the optimization phase, let's apply it. But we should never forget the time factor. In which phase are we? Not only when we start fluid administration, but also when we stop fluid administration. As Xavier indicated, if we continue for too long, the patient may become really edematous, and this is associated by itself with a worse outcome. So after the optimization phase comes the stabilization phase. Stop all this. The patient is stable now. And hopefully we will soon go into a de-escalation phase where the patient will eliminate that fluid. Perhaps we'll give a little bit of diuretics or ultrafiltration if there is renal failure, but we should now get rid of this edema that the patient will have had, no doubt about this. And hopefully we can also decrease the doses of vasoactive agents. Hopefully now the patient is fine and will leave the ICU after the ICU stay in a very good shape. Thank you very much.